This program is brought to you by Emory University.
Good morning, everyone. I think we have a quorum, and it is my pleasure to introduce this morning's Grand Round speaker, Dr. Joel Hardin. He is the medical director for Emory's Adult Congenital Heart Center. He completed his pediatric residency and pediatric cardiology fellowship at WashU School of Medicine in St. Louis. He has had an interesting career path over the years, holding various positions, including Director of Cardiac Intensive Care at the University of Chicago Children's Hospital, Medical Director of the Children's Heart Center in New Jersey, Vice Chairman of Pediatrics for Loyola University Medical Center in Chicago. Over the past 15 years, he's switched to caring for adults with congenital heart disease, developing adult congenital heart programs in Chicago and Tampa, most recently directing the Tampa Bay Adult Congenital Heart Center until he was recruited to Emory in 2022. In addition to his clinical work in CHD, I'm sure most of you are familiar with the Doximity dialer feature on the Doximity app. It's one of my favorites. That was his idea that became that Doximity dialer, and he helped with development of that. He also served in the U.S. Navy Reserve Medical Corps, rose to the rank of commander, and was assigned to the U.S. Marine Corps, serving as an infantry battalion surgeon and deployed to Iraq. Today he's going to talk to us about Tetralogy of Fallot, probably one of the most common congenital heart defects that we take care of in adulthood. Joel, I'll turn it over to you. Thank you for being here.
Okay. Well, thanks, Wendy, and Pooja for putting me on the agenda. And I thought, the most important thing I've learned so far at Emory is you guys take care of very sick people here. And so I'm glad to be part of the team. I came from Tampa ostensibly to join this great team, but also, my second goal was to become a smarter doctor, and being surrounded by people like Wendy and all my partners certainly is making me a lot smarter hour by hour. So our agenda today is to become familiar with some of the common anatomic variations of Tetralogy of Fallot, as well as their surgical palliation and repair, both in the historical domain as well as the modern context. I'm also going to help you to understand the long-term determinants of health and prognosis in adults who have Tetralogy of Fallot, and we'll discuss the optimal timing for reinterventions that address the most common hemodynamic and electrophysiologic abnormalities in these patients. Before I get going, I thought I'd start with a little digression to acknowledge most people give credits at the end of the talk. I'd like to give credit especially now to our colleagues in general cardiovascular medicine and advanced heart failure who are on the service in the hospital. And as Wendy and I were talking just before the conference began this morning, our patient population is getting really complex, and sicker patients are being hospitalized at increasing frequency. So without you guys manning the front lines for our very small footprint adult congenital program, I don't think we could do anything close to what we've accomplished together. So I really want to thank you from the bottom of my heart. You do a great job when we call you and you accept these patients from near and far. And if there's ever anything I can do for you, I want you to know you can call on me as well. And then I want to also introduce some of the partners in the program. We've already met Wendy. She needs no introduction. She's probably the one person that I go to the most when I have the toughest questions that need an answer. And if you haven't met Rusty Rodriguez, he's officially the nicest cardiologist in the department, and certainly a guy that I go to when it comes to both our fellowship training, who he directs that program, as well as he just calms the situation down when it's getting to a point where it needs to be calmed. And then lastly, if you haven't met Christina Thaler, she's our newest arrival, finished her adult congenital training in Michigan. Yeah, I just hope you get the chance to meet her soon. She's a superb cardiologist, super smart, and has a special interest in cross-sectional and advanced cardiac imaging. So look forward to introducing the whole team to you if you haven't met us already. So a little background on ACHD before we specify a little bit more on tetralogy. This is a tsunami of patients coming our way. it's not going to stop rising in frequency in terms of hospitalization and encounters in the outpatient clinic, probably for many more decades. So right now, there are over 2.5 million patients with congenital heart disease in the United States, and many of these patients have severe forms of congenital heart disease. Our median age is always increasing. I think when I started about 15, 20 years ago dabbling in adult congenital heart disease, you'd have mostly the 20s, people in their 20s, and now they're getting up there. We've got a few patients. In fact, I think I'm up to number 4 in my series of patients over age 80 since coming to Emory. So yeah, this is an aging cohort as well as a more complicated cohort. The barriers that you and I are going to encounter with taking care of adults with congenital heart disease are many. Some are structural in our system, and many are related to the way we deliver healthcare in the United States. The guided care of transfer of care from pediatric to adult care is still not where it should be. In Chicago, it was less than 30%. In Tampa, I was lucky because we're kind of one of only 2 programs in the entire state. So we had about 60 to 70% retention from pediatric to adult. But I think it's closer to the Chicago number here in Atlanta. Wendy could correct me if I'm wrong. There are completely way too few adult congenital training programs and way too few adult congenital cardiologists. We're playing musical chairs within the programs for this more senior people, and the junior people are getting snapped up as soon as they, drop their pen after filling out their application for the board exam. We have insufficient financial support and resources for some of our most vulnerable populations, especially those that live remote from large metro areas and university centers like ours. And it's amazing, but still today, patients and even their caregivers, their parents, are often unaware that the person that's grown up with congenital heart disease is never cured, and they need lifelong care. And one of the vulnerable populations in particular are those that are aging, and as are their parents, with cognitive and psychological impairments. And this is going to be extremely difficult for all of us to care for people that have intellectual disabilities and have aged to a point where their primary caregivers have either passed on or moved on. And then case management, comprehensive case management. It's a big need. We're very lucky at our program to have a superb social worker, and I think short of the physicians that we depend on, if I had to put one more person top front and center, it's our social worker who helps keep the ship afloat. This is what it looks like as of a few years ago in the United States. You can see that Florida's down to 25 now. Actually, I think they replaced me already, so they're back up to 26. Georgia, at the time of this publication, I think it was in about 2020, they had about 9 ACHD docs. But I have to caution that many ACHD physicians have a sort of a side interest in ACHD. So they have the board certification, but their primary focus is in either pediatric cardiology or structural interventional cardiology, and they don't have always a gigantic focus on clinical patient care. So I was reminded by a patient one day what it's like to be around people like you and me. And this was a young adult, quite witty. He was very proud of his analogy. He said that the Planet of the Apes has 3 general categories: the structural interventional gorillas, the non-invasive cardiology chimpanzees, the mystics, the cardiac electrophysiologists who see things that nobody else can see. And then I said, well, what about us in the adult congenital community? And he said, you guys are the monkeys that live on the island of Bohol, Philippines. You're very few, very weird, and not too many people even know you guys exist. So I thought that was a great analogy. Thought I'd share that with you. So moving on, tetralogy. We get down to this now in the agenda we started with. The fundamental anatomic characteristics of tetralogy are twofold. You're going to have a ventricular septal defect and varying degrees of right ventricular outflow tract obstruction. And in the ventricular septal defect is not the typical type of ventricular septal defect where there's sort of unrest in septal formation. This is a sort of a miss where the 2 sides of the superior and inferior portions of the ventricular septum misalign or malalign with one another, and the conal septum or infundibular septum curls up underneath the pulmonary valve early in embryogenesis, and cardiac morphology changes irrevocably after that, and you get sometimes mild to moderate pulmonary stenosis and sometimes complete pulmonary atresia. So this is a spectrum of disease. The epidemiology, it's the most common cyanotic congenital heart defect, representing 10% of all heart defects that people can be born with an incidence around 3.6 per 10,000. And if you look back in the historical era before surgical palliation and treatment began in the post-war era, post-World War II era, it was a pretty poor long-term prognosis. Only 3% of the people still alive after 40 years. So I want you to also recognize that tetralogy is oftentimes just a small component of the overall health picture our patients present to us. And we have a very large number of individuals with genetic syndromes and single gene defects. And among them, you've probably seen patients hospitalized with Down syndrome. Another one called Alagille syndrome, characterized by the cholestasis and intrahepatic biliary atresia, bile duct paucity. Vacral association is a polygenic disorder, but has many other problems besides just the cardiac defect. Charge association, another common thing with tetralogy. These are individuals that have significant intellectual disabilities, very significant problems with their eyes and ears. And again, they are difficult to care for in the absence of an experienced caregiver. And then the probably the one that is highest in prevalence is the 22q11.2 deletion syndrome. You might historically see it referred to as DiGeorge syndrome, but I think the nomenclature is favoring the former. And it's about 15 to 20% of tetralogy patients with this gene, this 22q11.2 deletion syndrome. You'll see it at higher density, though, in people who have tetralogy and right aortic arch, and it goes along with other conotruncal heart defects as well. So a little historical journey through the beginnings of our field of congenital heart disease and congenital heart surgery. It goes back to like I said, around the end of World War II, when doctors in Baltimore, Doctors Blaylock, Tausig, and surgical assistant Vivian Thomas came up with an idea to shunt blood from the systemic subclavian artery into the pulmonary arteries. And that classic Blaylock-Tausig-Thomas shunt, first done in 1944, is still represented in the population of adults we care for. Like I said, I have about 4 patients like this. Interesting aside, when I read the op notes that these patients almost always have, it's amazing to me. They have a copy of their op note. And on the front side is the hospital bill. And one of them showed me the hospital bill for their hospitalization in 1960 when it came time for their complete repair, intracardiac repair. And that hospital bill was $7,000. And I think that patient stayed in the hospital for about 7 or 8 weeks. It's amazing. The front side, Dr. Tausig and Dr. Blaylock would not refer to their operation as the Blaylock-Tausig operation. They would say, this is patient 130 of our operation. So nice humility there. Around the same time in Chicago, one of the cardiac surgeons, later destined to be a famous congenital heart surgeon, Dr. Potts, created a different kind of palliation where you can side-to-side anastomose the descending aorta to the left pulmonary artery from a left thoracotomy. This operation was a little perhaps technically easier to do for some surgeons at the time, but it was a bear to take down. And so it was abandoned later. And in the mid-70s, another variation of the Blaylock-Tausig shunt took over. You'll also see a few patients out there from a perspective of the Waterston-Cooley shunt. This was early 60s in Houston, and anastomosis is made between the ascending aorta and right pulmonary artery. And any of these anastomoses between the ascending aorta and pulmonary artery, whether it be right or left, are hard to control. They very frequently would induce an uncontrolled torrent of pulmonary blood flow that raised pulmonary vascular resistance and later led to severe pulmonary arterial hypertension, precluding a complete repair. And just about 70 years ago this year was Dr. Lily High's contribution in Minneapolis. He was the first to do the complete repair of tetralogy inside the heart. He would, at this time in the era of congenital heart surgery, was cross circulation between usually a parent on another table with cannulation to the baby or the child, I should say. And cross circulation was the cardiopulmonary bypass circuit of the day. The operation would involve taking down any previous aortopulmonary shunts and then closing the VSD and relieving RV outflow tract obstruction. So what do we do today as compared to those early days? Well, right now, elective repair during infancy is the rule. Most surgeons and congenital heart programs in the United States caring for infants and children feel that a complete repair is ideally timed between the first 3 and 6 months of life, with a very low mortality at that age. And they'll even attack this problem in a critically ill neonate as long as there are a few prerequisites like satisfactory branch pulmonary artery size. Palliative procedures like those I just mentioned earlier are much less common, although they are still sometimes needed, especially when the center is not experienced in stenting the ductus arteriosus, or if the infant has anatomic constraints that preclude a complete infracardiac repair. And most commonly, that'd be very small branch pulmonary arteries. So here are a few depictions of the surgical objectives, both the VSD closure and the relief of RV outflow tract obstruction. If you look at the kind of trajectory of the field right now, most surgeons are approaching the VSD from a transatrial incision, foregoing the ventriculotomy that may not be necessary if you can do a valve sparing type repair. Sometimes, though, the VSD does have to be approached from a ventriculotomy. The relief of RV outflow tract obstruction can be supraannular with a patch above the valve and some pulmonary valvotomy done at the time of pulmonary arteriotomy. It could involve that plus a resection of some muscle below the pulmonary valve in the infundibulum, or it can often, in fact, be a complete sacrifice of the pulmonary valve annulus with a transannular patch. You can obviously tell from the lower diagram, this is going to completely disrupt pulmonary valve integrity. It will relieve the pulmonary stenosis, but you're going to be left with almost instantaneous severe pulmonary regurgitation that the child will age into adulthood with. So if that's not enough, this is sort of like that proverbial box of chocolates. You never know what you're going to get with tetralogy. There's about 4 or 5 important variations that are categorized, and then within each of these subcategories, you'll find almost infinite variation in anatomic severity. The classic tetralogy, the tetralogy with pulmonary stenosis, involves varying degrees of infundibular, valvular, and supravalvular obstruction. And then you get to the extreme, tetralogy with pulmonary atresia. Pulmonary atresia, or complete absence of the pulmonary valve, is often accompanied by complete absence or very, very hypoplastic central branch pulmonary arteries. And then how would the baby's or the child's lungs be supplied? Well, they get arteries, collateral arteries off their aorta. Many different parts of the aorta, ascending, transverse, some of the major branches of the aorta, and descending aorta can all contribute sources of pulmonary blood flow, either that are exclusive to the lobe they supply or jointly supplied by diminutive native branch pulmonary arteries. Tetralogy with absent pulmonary valve, or the absent pulmonary valve syndrome, is thought to develop, and I'll show you some images of this, thought to develop from in utero ductal insufficiency or ductal constriction, premature in utero ductal constriction. And what it results in is a pounding on the central pulmonary arteries. There's no egress from the pulmonary circulation in utero through the ductus back to the maternal placental circulation. So these pulmonary arteries get pounded with right ventricular, blood flow and become ectatic. And the major problem these infants have, in addition to their cyanotic congenital heart disease, is that the very large branch pulmonary arteries compress the central airways to the point sometimes of causing severe neonatal respiratory failure. There's a form of double outlet right ventricle I'll show you that is so-called tetralogy type. There are many types of double outlet right ventricle, but for purposes of today's talk on tetralogy, I'll show you an example of that. And then tetralogy coexisting with another major intracardiac defect, an AV septal defect, often seen in children with trisomy 21. And as you look at all of these subtypes, every single one of them often can pose additional challenges in terms of anatomy, with the coronary arteries taking unusual origins and courses. Sometimes dual anterior descending coronary arteries exist, one crossing directly across the right ventricular outflow tract where surgical attention might be needed. And then, like I said earlier, right aortic arch oftentimes is coexistent with these patients, this patient's intracardiac defect. So here are a few examples of those subtypes. The pulmonary atresia subtype, and you can get a glimpse of this. You can see how the branch pulmonary arteries are diminutive and certainly not sufficient to carry the right ventricular output, and without significant rehabilitation. So what the stages will be in this surgical palliation will be to gather up some of these MAPCAs, aortopulmonary collaterals, off the aorta wherever they originate, and try and unifocalize them into the center of the mediastinum, where either primarily or secondarily they can be ultimately joined to an RV to pulmonary artery conduit, usually a cadaveric allograft. And then now you have access to the branch pulmonary arteries through the right ventricle, and further rehabilitation by catheter could be then accomplished. As far as the limitations of this disease, sometimes, unfortunately, this never proceeds past the unifocalization stage. The VSD can oftentimes not be closed if the pulmonary vasculature is not sufficiently well developed to handle that entire right ventricular stroke volume, or in some cases the major aortopulmonary collaterals are so large they transform the pulmonary vasculature into a hypertensive circulation similar to Eisenmenger syndrome, again precluding VSD closure. And you can imagine any conduit that's put into a baby is going to be upsized many times as they grow into adulthood. So the absent pulmonary valve syndrome, just a little depiction of that right here. You can see, as I said earlier, the pulmonary arteries centrally are very ectatic and compressing central airways. So the job of the surgeon for this one is to not only close the intracardiac defect, the VSD, and relieve any infundibular outflow tract obstruction, but also to sort of plicate down these large pulmonary arteries and do some pexy of the pulmonary artery so that it's not so compressive upon the central airways behind it. And even with that all that done, the need for reoperation is very high. And this, unlike the tetralogy with pulmonary stenosis, has a very high neonatal mortality. Lastly, the double outlet, excuse me, not second last, the double outlet right ventricle, the tetralogy type. Just a couple points on why we designate this as double outlet. Most of the double outlet right ventricle patients have subaortic infundibulum, represented here on this diagram, of muscle that can get in the way of blood flow from the left ventricle to the aortic valve. So the surgical approach to this disease is a little bit more challenging. You have to render the pulmonary valve unobstructed, of course, and the RV outflow to the pulmonary artery unobstructed. But you also have to close the VSD in such a way as to bring that patch through the right ventricle into continuity with the aorta without creating a subaortic obstruction at the same time. And frequently, these patients will need reoperation for LV outflow tract obstruction or subaortic stenosis as they grow older. And then the last anatomic variant you'll see out there, this is oftentimes a very challenging substrate because the coexistence of a complete AV septal defect, a large inlet VSD, a large primum ASD, a single AV valve instead of two, can sometimes make this operation not amenable to a biventricular repair strategy, and this will go down the Fontan pathway. So this is that rare tetralogy substrate that will go down a single ventricle palliation pathway. And again, you might imagine that if it does, then the risks and the long-term burden of disease is much greater. Okay, so what are we going to see in adults? Well, that's the history of surgery and the various anatomic variations. The most common problems you're going to see in adults, chronic pulmonary regurgitation, that probably stands right out there at number one. its secondary effects on the right ventricle and right ventricular dysfunction. You can have residual defects, residual VSDs, residual pulmonary stenosis, and unfortunately, there's a very high prevalence of arrhythmias, sinus node dysfunction, and atrial and ventricular arrhythmias, with a lower percentage having complete heart block. And there's a temporal association with aging, with tetralogy and its surgical history, and endocarditis increasing year by year as you age after your childhood surgery. And even with some of the transcatheter valves emerging on the scene, we're starting to see quite a bit of endocarditis in addition to what we saw before. And then the prevalence of sudden death, that's definitely a big problem for this population, as high as 6%, depending on some of the anatomic substrates and other electrophysiologic variables. And we'll go over some of that here shortly. So some of the things I like to point out when meeting patients and also sharing the clinic with trainees is what determines long-term outcomes. Well, the poorer outcomes, not surprisingly, going to be in those who aged into childhood and had their primary intracardiac repair many years after being born. They've been exposed to cyanotic conditions for years and probably had many palliative steps along the way. So they've had sternotomies, thoracotomies, the burden of arrhythmias emerging earlier in their life. So those patients at greatest risk seem to be right now our oldest patients. The valve sparing techniques that are now commonplace in congenital heart surgery programs do preserve and limit the amount of pulmonary regurgitation and its secondary downstream effects, but they do have arguably a little higher rate of reintervention, especially during childhood. And so there's a little bit of a trade-off there, but I think most congenital heart surgeons, when given an opportunity to repair this condition with a valve-sparing technique, will definitely jump at it. The transannular patch is a risk factor for late ventricular dysfunction and arrhythmia, and even sudden death in some series. Again, this is disputed in some other centers, and I'll acknowledge that. But in general, a ventriculotomy is a bad thing. And so where possible, most of the congenital heart surgeons are trying to avoid or minimize ventriculotomies. And then, like I said earlier, the degree to which you have chronic pulmonary regurgitation really drives the outcome. So let me shift into, I'm going to save a little bit of the pulmonary regurgitation talk toward the end and talk a little bit more in detail about the hemodynamic variables associated with sudden death, and then some of the arrhythmia related considerations associated with sudden death in this population of adults. So you can see the various subtypes of arrhythmia and how their prevalence is affected by the presence of residual pulmonary stenosis, defined here as a right ventricular systolic pressure in excess of 60. The presence of secondary tricuspid valve regurgitation. This is a functional tricuspid valve regurgitation in the sense that the annulus is usually enlarged from the chronically enlarged right ventricle rather than something intrinsically wrong with that tricuspid valve, as you might see in Ebstein's anomaly. And then with increasing grades of pulmonary regurgitation, moderate and severe, you're going to see ventricular tachycardias, sudden death, atrial fib and flutter, and other problems increase in frequency. The surface ECG is, believe it or not, quite predictive and in the history of our understanding of risk factors for sudden death after tetralogy repair. Something as simple as the QRS duration seems to track nicely with the anatomic impact of chronic pulmonary regurgitation, so that ventricular tachycardia and sudden death, you start to see those that incidence at its greatest when the QRS duration is in excess of about 180 milliseconds. Atrial arrhythmias also coexist with tetralogy patients at increased frequency, and one of the studies that I was involved with in Chicago peg that number at around the QRS duration around 160 when you start to see AFib and aflutter emerge. Very few people are arrhythmia free with tetralogy. That's the most important take-home message I can give you. The EP study variables associated with sudden death. I won't even pretend to be as smart as the orangutans in our section of electrophysiology, but they are often called upon to evaluate these patients and their risk for sudden death and the potential benefit for a primary prevention strategy for an ICD implant. And that's becoming increasingly frequent as we enter the era of transcatheter valve replacement, with where a stented structure is implanted across the right ventricular outflow tract, caging that portion of the vulnerable myocardium from future interventions. So a lot of times you'll see us refer a patient for an EP study perhaps before they get a transcatheter pulmonary valve. The highest rate of sudden death in this population is when there is a polymorphic ventricular tachycardia induced during EP study. And you can see that just a pretty poor freedom from clinical VT in that setting. All right, so heart failure. So arrhythmias and heart failure, I think we can just pretty much say that's what it's like to be an inpatient attending on the HRSA service and the advanced heart failure service with our patients. You're being asked to care for arrhythmias and heart failure, no matter what the anatomic substrate is. But tetralogy is no exception to that. And in the age that we're talking about, the various patients over 20, you can see the increasing prevalence of heart failure as they get older, approaching over 50% plus by the time they are my age and older. And as far as the differences between era when these patients have been treated and operated on, you can see there's a big difference. There's a lower prevalence of heart failure when you're taking care of a younger population of patients. But even then, the one message, yes, sir? Oh,
you slept here, dude. Yeah.
Okay, I think that's just a background noise. Even then, the trajectory of heart failure is still not slowing down. It's just lower in the earlier years. So I think the most important thing I can tell you is be ready for more and more patients with tetralogy, more and more patients with heart rhythm problems and heart failure problems coming into hospital. I stole this one from good friend Andrew Reddington. This slide he showed probably at one of my first adult congenital heart meetings many years ago. And it just sort of drove home the burden of pulmonary regurgitation on our vulnerable right ventricle. And I'm indebted to him for sharing that slide. It affects at least a third, and I think arguably probably more of the survivors of long-term tetralogy repair. And its duration and severity is directly linked to the prevalence of RV dysfunction, arrhythmia, and sudden death. Our goal as adult congenital cardiologists is to intervene with a pulmonary valve replacement strategy before RV dysfunction becomes irreversible and those other secondary downstream arrhythmia events have occurred. The timing of intervention is a moving target. I think no one would argue, though, that when we're presenting cases for pulmonary valve replacement, either surgical transcatheter, if you're symptomatic with plausible symptoms linked to RV dysfunction and pulmonary regurgitation, like exercise intolerance, edema, and arrhythmias, we're going to prioritize you for an intervention. For those that think they're asymptomatic, but we identify poor performance on a cardiopulmonary exercise test, that's another category we pay a special amount of attention to. And then we have some, again, like I said, moving targets, the end-diastolic and end-systolic right ventricular volumes by MRI. They started at around 170 on the end-diastolic volume index to body surface area. We've moved that target down to around 150 when all other factors are equal, and around 80 for the end-systolic volume. This is all indexed to body surface area. But you might imagine we have a wide spectrum of patients who have widely varying body surface areas. So it's a little misleading sometimes to look at these numbers and say, well, you're not quite to our threshold numbers. So we'll occasionally just use the ratio of RV to LV volumes, and especially during diastole. If you got a right ventricle that's twice as big as your left ventricle, that's probably a right ventricle that is approaching the irreversible stage of dysfunction. We do look at the pulmonary regurgitant fraction. Of course, you can imagine you can have right ventricular enlargement from other reasons. And if the pulmonary regurgitant fraction is low, you have to be on a hunt for other possible causes of the right ventricular enlargement, including problems with the tricuspid valve, pulmonary hypertension, etc. And then these are not right and left ventricles sitting in isolation from one another. Anything that's going wrong with the right ventricle can affect its neighboring left ventricle, especially in advanced stages of disease. So left ventricular dysfunction commonly coexists with advanced stages of RV dysfunction. And when present, imparts a much higher risk of sudden death and ventricular arrhythmia. And then, like I said earlier, we'll use the ECG criteria as ECG criteria, and they are important, and they should be mentioned in our analysis of who's going for pulmonary valve replacement and why. So some of the other tools I mentioned already, we've moved the target down for MRI-derived measures of RV size to around 150 and 80 respectively for diastole and systole. RV ejection fractions, when you have poor RV function, it's hard to sit on that patient when they have chronic severe pulmonary regurgitation, no matter what else is going on. And we certainly want to get to them before the right ventricle has enlarged to a point where now you've got two valve disease on the right side, and you're going to need additional work on the tricuspid valve in addition to the pulmonary valve replacement. And again, arrhythmias, once they are sustained, baked in, it's, again, I wouldn't say that we expect them to go away with pulmonary valve replacement, but we hope that at least they won't continue to progress in terms of severity. Now, what are our options? Well, we have surgical and transcatheter. The surgical option that is most commonly deployed is a bioprosthetic valve, but there are going to be patients who can't get that and have had a right ventricle to pulmonary conduit, whether it be a cadaveric allograft or a synthetic vascular graft with a valve inside of it. And only rarely will a mechanical valve be placed in the pulmonic position. In the transcatheter domain, there's two schools of thought and two options being deployed depending on the center you're working in. A majority, I think, favor the surgical approach to the primary pulmonary valve replacement scenario. But there are patients that just do not want to go down another sternotomy for whatever reason. Maybe they have had other complications with the sternotomy and or they just prefer to go down the route of a primary transcatheter valve implant. There are fewer people that can accept a transcatheter valve implant as a primary intervention, but that number is increasing. And right now, with all the transcatheter valve options emerging, we can probably get a valve into roughly around 80%. I wonder if Basilis would agree with that, but I think it's around 80% of people who come to a pulmonary valve replacement might be a candidate for a transcatheter option. But for sure, after a surgical valve has been implanted or a conduit has been implanted, we can get a valve inside most of those, subject to a few anatomic limitations. So I'm going to spend a little time on this article. It's already 10 years old, but it forms the basis for some of our current practice. And I just wanted to point out some of the demographics and clinical characteristics of a large population of patients reported back in 2014. The median age at that time was a little younger than our median age today, but still in the fourth decade, I should say. And the vast majority had undergone prior surgical palliation. Their complete repair, when it had finally taken place, was dominated by transannular patch. And how many sternotomies? 1, 2, or 3? There are probably some people out there with 4 or 5, but the vast majority, this was somebody who's coming for a primary pulmonary valve replacement after earlier childhood repair with a single sternotomy. But that number is changing. If I were to redo these data today, I'm sure we would have a 4 and a 5 and maybe even a 6 sternotomy column. And the shift toward 2 and 3 sternotomies before pulmonary valve replacement for a second or third time is going to be much more obvious. A previous pulmonary valve replacement at that stage in 2014 occurred in about 12% of these patients. You can see most of them were class 1 or class 2. Very few, thankfully, are class 4, and very few are operated on in decompensated heart failure. And that's our current practice today, that we don't believe that's the right time to do this. Arrhythmia substrates at the time of a pulmonary valve replacement, mostly we're talking VT, but atrial arrhythmias do exist at a pretty high rate, and pacemaker for AV block has also been present in some of these patients. There's their ECG QRS duration, so you can see they're skewed a little bit smaller QRS duration than the threshold for VT and sudden death. I think that was informed by the studies of the early 2000s. And look at the peak pre-op VO2. More than 60% had a better than 70% peak VO2. So this is a pretty healthy patient population, informed by what happens if you don't operate early enough, and some of the higher rates of complications that come from operating late. Here are the CMR data that this cohort had. You can see their volumes are a little bit smaller than the 170, which was in the era prior to 2000s for RV and diastolic volume. So that's where we're getting around the 150 mark that I mentioned to you earlier. The RV to LV ratio, about 2 to 1. And the ejection fractions are mostly normal on the right side at the time of pulmonary valve replacement, but that's not typically going to be the thing you see in the hospital. We're seeing a lot of patients, of course, with heart failure and a poor RV function at our referral centers. Pulmonary regurgitant fractions are pretty high, approaching 40%. What kind of valves are put in? These are typically going to be xenograft valves, sort of like bovine or porcine or bovine valves, with a very small percentage still today with homographs or vascular conduits. A lot of these are done on beating heart, about half. So if you don't have an atrial septal defect, and this is the only surgical objective, this heart does not need to be arrested with cardioplegia, and therefore the complications of postoperative low cardiac output syndrome are perhaps mitigated by that approach. As far as the type of valves, I just sort of split them out for you. This is surgeon dependent in large measure. I think here our congenital heart surgeons like the bovine pericardial valve over the porcine valve. I think there's probably no strong opinion that I could issue regarding one versus the other. The size of these valves, they're getting pretty large. They're between 23 and 29 millimeters. That allows for a valve-in-valve secondary pulmonary valve replacement option later. Okay, the survival after surgical pulmonary valve replacement is depicted here. You can see that those with the lowest preoperative peak VO2 do worse. And so I think we've learned now that the best strategy for the person who comes to us in clinic with pulmonary regurgitation and RV dysfunction or RV enlargement is to take that I'm symptom-free statement they give us with a grain of salt and verify that. And if they do have really good peak VO2, it's actually kind of encouraging at that moment to say, your RV is starting to struggle. Now may be the time for the lowest risk pulmonary valve replacement strategy, rather than waiting for you to get sicker. And I think that's the smart way to go, even today, 10 years later. Okay, the survival after surgical pulmonary valve replacement, I just put out 2 cohorts here, the early cohort before 2005, and then a later cohort. You can see again, we've gotten better at selecting patients, and therefore our survival statistics are improving. And I think this is only going to get better as long as we continue to have access to our patients. The biggest barrier, I think, to this the statistic, the survival statistic getting better is going to be patients getting access to us. And the freedom for reintervention, you can see about 10 years out in this one study cohort was pretty good, more than 96%. We're still free of a reintervention by the time they were 10 years post-surgical pulmonary valve replacement. So a pretty good number, and we've got several anecdotes that are above 20 years in the practice as well. So a few last slides on this study, just to point out that we do recognize, as I said earlier, that QRS duration can predict the probability of sustained ventricular arrhythmias in sudden death. But I want to emphasize that at least in this study cohort, the QRS duration did not significantly shorten after pulmonary valve replacement. So what I'm trying to get at with that statement is what the authors concluded as well, is that the risk of sudden death and ventricular arrhythmias never leaves. it just hopefully won't get worse. Shifting briefly into the domain of transcatheter pulmonary valve replacement, this could occupy a several-day talk, but the beginnings of transcatheter pulmonary valve replacement are almost 2 decades old, and now we have several valves on the U.S. market. I put 3 of them up there right now for you. The Melody valve is a balloon expanded crimped valve on a stent that you see on the picture upper right, excuse me, upper left to me, and it is sized to approximately 22 millimeters. The Sapien and Harmony valves are different in terms of sizing. The Sapien valve can get upwards of, I believe, 29 millimeters or thereabouts, and the Harmony valve is interesting. It's meant to deploy into outflow tracts that are very patulous, and you can see it's kind of got an expanded distal and proximal segment within which the valve is sewn, and this kind of hugs the landing zone that's assessed to be suitable for this valve's deployment. Most of the valve deployments are done by teams that are involved in a sort of core lab affiliation, where the CT angiograms of the patient's heart are submitted, analyzed, and some predictive models are made of the probability of landing the valve in an appropriate position. There are many other valves, though, in development, including self-expanding valves and others that will increase the number of patients eligible to receive either primary or secondary transcatheter pulmonary valve replacement. But it's not without risk, and the Melody valve, one of the first generation valves here in the United States, was particularly vulnerable to some stent fractures over time, about a third. The conduit that these were placed into would often rupture. Of course, it's not the end of the world. These catheters are good. You can get a covered stent inside the ruptured conduit usually pretty easily, and then proceed with a secondary valve in valve kind of concept. But it is a significant risk with a heavily calcified RVDPA conduit. Coronary compression. You can see the image here. At the same time, they're blowing up a balloon across the presumed landing zone, or the presumptive landing zone. They're looking to see if that balloon expansion obliterates the adjacent coronary lumen, and if so, that's a patient you don't want to be deploying these valves in. And then lastly, endocarditis. This is, like I said earlier, a temporally related phenomenon. The longer the valve's been in, the higher incidence of endocarditis we're seeing. It seems to be one of the most common late failure mechanisms, other than calcific degeneration or just valve regurgitation due to leaflets that are frozen and such. So I'm going to end with a few minutes left to take a few questions if you have them, by summarizing that cardiac reinterventions, symptomatic arrhythmias, heart failure, endocarditis, very common, increasingly dominating the inpatient wards of our patients with tetralogy of Fallot in the hospital. Event-free survival is not too good. Only about 25% will reach their 40th birthday without having a significant event, as one of those I just mentioned. We are still trying to refine the optimal timing of pulmonary valve replacement, although I think we're getting better, and I think there's no doubt that intervening in the less symptomatic patient with a better functional capacity by cardiopulmonary exercise testing can help guide the best outcomes. So appreciate the chance to talk briefly on this topic, and welcome any questions on the chat.
Thank you, Joel, for excellent talk on tetralogy of Fallot. We are open for questions. If people have questions, I'll do my best to figure this out. While we're waiting on questions, Joel, I, as a fellow, gave a talk on the timing of pulmonary valve replacement in tetralogy of Fallot, and I wish I could say that we're smarter then and knew the definite answer to that question many decades later, but we still struggle with this. I've learned earlier is better. Do you have any thoughts on those patients who don't meet volume criteria? Are there certain circumstances in which you would go ahead and replace the pulmonary valve in the setting of free PI, but without hitting that magic MRI volume number?
Yeah, I think we all share those patients. And one category of patients in particular are those whose right ventricles have taken so much of an insult throughout their lives that now they have almost restrictive physiology, and they do have restrictive physiology, and the regurgitation is sort of impeded by the already very high RV diastolic pressures and relaxation problems. They're going to be much more symptomatic at a lower volume of right ventricular size, and of course the pressures will equilibrate between pulmonary arterial diastole and RV diastole, so that you may not see the MR characteristic of a pulmonary regurgitation fraction of 40% plus. So when you have indices of RV dysfunction that include restrictive problems, like, for example, you look at these echoes and the Doppler flow pattern of flow across the RV outflow tract is not antegrade just during systole, but it's antegrade during diastole. That's a very sick right ventricle. Probably should have been tackled earlier if at all possible. So that's a particular patient population I think we could be fooled.
All right, thank you. Any questions from other people on today?
Hey, Wendy, Steve Clements.
Go ahead, Steve.
Hey, Steve.
That was great. Thanks so much. Absolutely great. So I remember what happens to the QRS when you make that right ventricular incision, and it gets really wide, get right bone branch block with it. What was the reason to change that? Number one, are the ventricular arrhythmias coming from that right ventricular lotomy? And number two, did they change to the supravalvular approach, trying to get rid of that infundibular muscle because of the arrhythmias, or probably other reasons, like it's never good to slice on the ventricle? Or can you comment on that?
Yeah.
That change
so,
of those arrhythmias?
Yeah. So when the electrophysiologic mapping of ventricular tachycardia is done, it is localized in many patients to scar tissue related to an infundibulotomy, and scar modification can only do so much. I mean, if you have the surgical approach to try and remove scar, all you really done is remove the scar that was old and created a new scar. So trying to avoid it to begin with. The surgical approach to relieving RV outflow tract obstruction through the pulmonary valve is going to be inherently limited to only patients that have a large enough pulmonary valve annulus to expose the RV infundibulum. You can also get some of that muscle out through the atriotomy that the surgeon will use for a VSD repair. So some can be taken out from an atriotomy, some can be taken transpulmonic, but the smallest and the tightest of the infundibular obstructions still need a ventriculotomy, and there is the long-term risk for scar-mediated VT in that population.
A quick question about just people with congenital heart disease, but TECs in particular. As they're living longer now, I'm just wondering, has anybody looked at the impact of just common risk factors that we have in just adult, world, like obesity, for example, and impact on pulmonary regurgitation or the timing of the valves? Or
yeah, and I think that's a perfect question that the staff that has a link to the CDC might be able to help me with. Wendy, do you have any more global lifestyle and patient characteristic data in that regard to share?
I probably do, but not off the top of my head. We have a couple of publications coming out on that shortly, so be able to share that. But they do have similar problems as the rest of the population, particularly hypertension and heart failure.
because, I'm just thinking that our usual thing is that, if somebody has congenital, we just say, okay, it's congenital heart disease, but there's probably, the usual risk factors of treating the hypertension or, diabetes, etc. I don't know that there are any specific guidelines on that.
I think you should just take care of the whole patient like you do with every other member of the patient population you encounter. So obviously, a person with congenital heart disease can ill afford adding insult to their already birth injured heart. So I think often our sickest patients that I see, the ones that have so many more perioperative risks, medical hospitalizations, are those that are obese, diabetic. They have predispositions toward chronic kidney disease. These are all problems that unfortunately just add further jeopardy to already a tough situation. So try and treat everything. At least, we should. Yeah. I tend to focus a lot on the congenital heart disease aspect of the patient population I care for. But here at Emory, I'm forced to become a better doctor in those other domains.
All right. Any other questions for Joel? No? All right. Well, thank you so much for an excellent talk today. We really appreciate you sharing history of tetralogy of Fallot and how that impacts present day tetralogy of Fallot patients, along with some guidelines for their care. Thank you all very much.
The preceding program is copyrighted by Emory University.